Hi, good evening, friends. Today I have some work at 7:30, so I have preponed the class to 6:30, and I'm happy that most of you have logged in. Most of your exams are fast approaching, probably starting from 1st of April, and that's why I request all of you to attend to my classes live because it may take some time for me to upload these lectures on YouTube. So let me conclude today the management of monochorionic twin problems with monochorionic twins. I was talking about Quintero stage 5, that is single fetal demise. I explained that yesterday. Today, I want to just summarize before I move on. The management of single fetal demise in a case of TTTS. After single fetal demise, prompt delivery of surviving twin is not necessary. That means immediate delivery of the surviving twin is not necessary. And not only that, it is unwise unless the overall situation is conducive for continuation of pregnancy. Sorry, unconducive for continuation of pregnancy. That means suppose there are other comorbidities which has led to the demise of the fetus, then probably yes. Otherwise, if it was purely due to TTTS, there is no need to immediately deliver the surviving twin because the damage occurs, whatever damage occurs, that occurs at the time of demise and not after that. So after that, you have to simply monitor the surviving twin and take a call depending upon the situation. Okay, now I'll go to another situation or topic called persistent or recurrent TTTS. What is that? The incidence of recurrent TTTS ranged from 0 to 16%. It may be because of residual anastomosis that can lead to persistent or recurrent TTTS. They may have been missed at the time of laser ablation or revascularized after the procedure. Whatever it is, there is persistence of anastomosis, which is giving rise to persistent or recurrent TTTS. Measures for reducing the risk of residual anastomosis include more careful scrutiny of the placental margins. How do you manage this when it persists or it recurs? It again depends upon Quintero stage and gestational age. As we understood yesterday, Quintero stage 1 to 5, you know that. Just to recapitulate, in all stages, there will be oligopolysequence. Stage 1 means just the oligopolysequence, bladder is seen, Dopplers are normal. Stage 2 means bladder disappears. Stage 3, Dopplers become abnormal. Stage 4, hydrops fetalis. And stage 5, single fetal demise. So expected management is usually suffices because you would have already done a laser therapy. This would be, if at all, a mild TTTS, maybe going on for TAPS. You may repeat fetoscopic laser ablation if you think the problem is still large, or if you think that the gestational age has crossed 26 weeks, you may just resort to amnio reduction because laser becomes difficult after that, which I explained yesterday. Now there's one more entity called reverse TTTS. That means the donor becomes recipient and recipient becomes donor. It's a rare occurrence post-laser in which each twin assumes the former phenotype of the co-twin. As I said, the donor becomes recipient and recipient becomes the donor. The former donor develops polyhydramnios and the former recipient develops oligohydramnios. This is like reverse TTTS. It is unclear how the apparent reversal of the transfusional gradient occurs. So there was one-way gradient and it suddenly reverses, maybe because when you ablate few vessels, there could be reversal of the thing, or it can occur spontaneously as well. When present, the outcomes are compromised with overall survival rates less than 50% because initially one fetus was compromised, other fetus was doing okay. Now, when the roles reverse, the other fetus also gets compromised. So both will get compromised. That's why the survival rate is less than 50%. Okay, now we talked so much about laser ablation, thinking that it's one which is going to solve the problem totally. Yes, it helps, but there are complications with laser ablation as well. First of all, it can give rise to PPROM, and that can again lead to preterm delivery or very early preterm delivery as well. Preterm birth, average age is 31 to 34 weeks, which is okay. Membrane separation, which can lead to again preterm labor because of the secretion of prostaglandins. Intra-amniotic bleeding during procedure. Of course, sometimes it will seal off itself, not a big problem, but if it continues, that could be a problem. Fetal demise, very unfortunate, 10 to 30% of the cases, that is a possibility. What it means is that you have to explain to the patient all these complications before you take up the surgery. But while saying so, you should say that something like the air hostesses, how they say it, in the unlikely event of the flight landing on the water and things like that. You should say this in a manner where the patient does not get scared at all. What are the long-term maternal effects? No adverse long-term maternal effects after fetoscopic laser therapy with respect to subsequent fertility, because you're not going to do anything with the uterus, it's only the vessels in the placenta. Obstetric and gynecological outcomes are also not affected at all. What are the outcomes of TTTS? Overall perinatal survival after laser therapy of stage 1 to 4 was 65%, which is very good. Approximately 33% of pregnancies had one survivor and 50 had two survivors. That is also quite good. Survival is higher with stage 1 and 2, obviously, and lower with stage 3 and 4, again understandable, where Dopplers changes have already taken place and there is already hydrops fetalis. May have chronic kidney disease and pulmonary valve pathology in some of them that may persist, because already we have seen that vasoactive substances are produced both in the kidney and heart. What about the neurodevelopmental impairment? At birth, 6.1%. At 6 to 48 months, 11.1%, both with no significant differences between donor and recipients or pregnancies with 1 versus 2 survivors. Both will suffer. Donor also will suffer, recipient also will suffer, and if there is 1 survivor, that also will suffer. If there are both survivors, that also will suffer. But thankfully, it is not very high. Cerebral palsy can occur in 39.7%, especially if the babies are delivered extremely prematurely. Yes, now I can take a breath. I have finished with TTTS. Now I go to the second major complication of monochorionic twins, that is called twin anemia polycythemia syndrome, in simply TAPS. I told you day before yesterday, the part 1 itself, that it is milder version of TTTS. Here also there is transfer from one baby to another baby, one vessel to another vessel, but the anastomosis are very, very minimal, and probably the anastomosis are slightly balanced. Yes, there you are. TAPS is mild variant of TTTS. An atypical chronic form of TTTS caused by slow transfusion of red blood cells. Like in the surgery, we jokingly tell this surgeon is so careful, he is not only catching the vessels, but he catches the RBCs, something like that. Here, there is no big flow from one vessel to another. It may be just a small leak of red blood cells through a very small, less than 1 millimeter diameter of placental arteriovenous anastomosis. It's a very small leak, and leak of not so much of blood and fluid, just the RBCs. That's why in this case, anemia is more important, or anemia is more prominent rather than the oligopoly sequence, resulting in anemia of one twin and polycythemia of the co-twin, not polyhydramnios, polycythemia. What are the cardinal findings? MCA PSV is more than 1.5 MOM in one twin, which is typical of anemia, and less than 0.8 MOM in the other twin. There's a huge difference, as you can see. Amniotic fluid volumes are normal. That is very, very important to understand. There is no oligopolysequence here. It's just the difference between two fetuses as far as the MCA PSV. One is 8 and other one is almost double. What's the cause? As I already told you, TTTS with few anastomosis and no artery-to-artery communications before laser ablation. Post-laser TAPS occurs sometimes, which you have done for TTTS in 2 to 13% of the pregnancies treated with laser ablation up to 6 weeks after procedure. Maybe the patient had TTTS, you did the laser ablation and blocked all the leaking vessels, but still you would have left few of them. Now, lot of fluid won't go from one baby to or one sac to another sac, but RBCs are still crossing. So it is something like post-TTS TAPS. I hope it's clear. TAPS may also occur spontaneously. That's most of the time. What are the stages? Like Quintero staging in TTTS, there are stages in TAPS as well. Stage 1 MCA PSV difference is that one twin has 1.5, another has less than 1 in the recipient without other signs of fetal compromise. Like I told you there, what is common is oligopolysequence here. What is common is disparity between MSV, MCA, PSV. One twin has more than 1.5, another one has less than 1, usually 0.8. Whereas when it comes to stage 2, as you can see, the MOM increases in one twin that is more than 1.7 now, and the other twin decreases less than 0.8 without other signs of fetal compromise. Whereas stage 3 could be stage 1 or 2 with regards to MCA PSV, plus cardiac compromise of the donor by any of the following. What is that? Absent or reversed end-diastolic velocity in the umbilical artery, pulsatile flow in the umbilical vein, increased pulsatility index, reversed flow in the ductus venosus, that is reversal of A vein. Stage 4 is again stage 1 or 2 plus hydrops. Remember in TTTS also stage 4, Quintero staging, stage 4 is hydrops. Here also hydrops of the donor because of severe anemia. Stage 5 is almost the same, single fetal demise. What we said here also, it is demise of one or both the fetuses preceded by TAPS. So the Quintero staging and this staging is almost similar, except that in stage 1, we talk about the difference in the MCA PSV, whereas there we talk about oligopolysequence. Stage 2 and stage 1 differ in the sense we don't talk about bladder here, we only talk about the difference in the MOMs. Stage 3 is cardiac compromise, stage 4 is same hydrops, stage 5 is demise. What is the postnatal classification of TAPS? See, these are all based on the Doppler studies in the middle cerebral artery. But after birth, you can actually make out the difference in their hemoglobin, isn't it? So based on the degree of hemoglobin difference between the twins, we classify them further. Stage 1, the difference is more than 8. There also it is more than 8 if you remember. 0.8 and 1 point, almost you can put it as 6. So difference is 8 in the MOM. Here difference is 8 in the hemoglobin. Easy to remember. Whereas stage 2 is hemoglobin difference is more than 11. Stage 3 more than 14. Stage 4 is more than 17. It's almost like one baby is having 17 grams hemoglobin, other baby having almost 0, I think. And stage 5 is more than 20. That much of difference is, I don't think that baby survives. What is the treatment of TAPS? Based on progression of the discordance between the two twins, here the laser ablation and all that is not going to be very useful because the leak is so small and the vessels, the connections are so small. Instead of that, you straight away start treating the baby, something like what you do in case of RHIS immunization, which also gives rise to hydrops fetalis, isn't it? So here, if you see that MCA PSV of more than 1.7 MOM in one and less than 0.8 in the other, that is an indication for intrauterine transfusion to the anemic fetus. TAPS after laser ablation. Suppose you find a post-laser TAPS where initially it was TTTS, then you gave laser therapy, and then it has come down to now TAPS, milder version of TTTS. You may, in such cases, repeat laser therapy. But if you think laser therapy is difficult now because the pregnancy has grown beyond 26 weeks, you can opt for intrauterine transfusion, which is like a direct treatment of the baby rather than prevention of the leak. Laser only prevents the leak either of the fluid or of the RBC, whereas intrauterine transfusion straight away treats the baby. Definitely that is better, isn't it? Or if you think that the difference is not so much, you can simply wait and watch what is called expectant management. And whatever it is, early delivery is better because, you know, these babies, we can give transfusion outside the mother's womb easily compared to intrauterine transfusion. So deliver them early and hand over them to the competent neonatologist. Or the worst case scenario, selective feticide, which is not at all a good option. At least I don't advise that. What are the outcomes of TAPS? The delivery of 2 healthy neonates most of the time, hopefully, and need of neonatal blood transfusion, that's fine. Partial exchange transfusion, also okay, but death of one or both the twins is not okay. Severe neurodevelopmental impairment was detected in 9% of the survivors and was also more frequent in the donors than recipients. Whereas in TTTS, we saw it is equal in donor as well as in the recipient, but it is more so in the donor here rather than the recipient, 18 versus 3%. The third complication of monochorionic twins is twin reversed arterial perfusion sequence called TRAPS. It is not to be confused with reverse TTTS. Reverse TTTS is different, wherein the original donor will assume the role of a recipient and the recipient will assume the role of a donor. Both the babies are okay there. But when you say twin reversed arterial perfusion sequence, it's a rare complication of monochorionic twins in which a living twin perfuses a non-living, what is called acardiac twin, through patent vascular channels. I hope I'm clear. I will repeat very slowly once again. Reverse TTTS is different. There, both the babies are normal in a way to start with. Because of the vascular channels, unbalanced blood flow between each of them, there will be oligopolysequence and other complications. But when you say twin reversed arterial perfusion sequence TRAPS, it is different. Here, one baby is living, other baby is non-living, acardiac baby, but that will bleed into another. So actually, there the things are very clear. So we have to terminate them early. Probably the other babies anyway is not the live baby. So the fourth complication of monochorionic twin is selective fetal growth restriction, right? So where weight of one twin is less than 10th percentile, that's how we after all diagnose the FGR, even in a singleton baby, or the discordancy of more than 25% in estimated weights. None of the babies are less than 10th percentile, but the difference between the two may be more than 25%. I hope you know the difference between percentile and percent. Percentile is when you arrange the babies in the ascending order of their estimated fetal weight, the 10th baby. But when I say 25%, the weight difference will be 25% difference between the two babies, right? So that is not to be confused with. The discordancy can be calculated with a simple formula of weight of the larger twin minus weight of the smaller twin divided by weight of the larger twin. What are the causes of selective fetal growth restriction? It is often due to unequal placental sharing. When you are to share the placenta between the two fetuses, there is unequal placental sharing. Anyway, that's the cause of the whole problem in the world, unequal sharing. Discordancy in placental territory. Territorial wars are going on all over the world. Umbilical cord insertion abnormalities. That also is the cause of selective fetal growth restriction. Unequal splitting in the initial cell mass itself. You remember this twin, to start with, it was, let's say, monozygotic twin, and then it starts splitting. Right in the beginning, when it was splitting, before it became dichorionic, the cell mass, one may get more, one may get less. It's like property distribution. So one who got less endowment right in the beginning, throughout pregnancy, it will be smaller only. The other one may be normal, AGA. Imbalance in bidirectional flow between the circulations. That is, again, maybe something like because of TTTS, it can have the problems. What are the types of SFGR? In everything, there is a type. In TTTS, there is quinterous staging. In TAPS, there is five types again. And in SFGR also, there are different types. Type 1, normal Doppler flow in umbilical artery. Always type 1 will be normal most of the time. Mild inter-twin weight discordance, but minimum 25, but not more than that. Usually favorable outcome for both. Obviously, when the mild discordancy, both will be okay. Very low risk for fetal demise of FGR twin. So almost everything is there, except that one of the twins may be less than 10th percentile. That doesn't mean that that baby has to die. Even singleton babies, just a FGR will not kill the baby. Severe FGR will kill the baby, yes. Type 2, absent, now starts the problem in the Dopplers. Absent or reversed end diastolic flow in umbilical artery, which obviously have poorest prognosis, and high risk of fetal demise of FGR. So prognosis is bad, or there can be death also. And mean gestational age at delivery is 29 weeks. They don't cross that because maybe iatrogenically we induce delivery or do cesarean delivery. Type 3 is intermittent absent or reversed end diastolic flow in umbilical artery. Intermediate prognosis, 10 to 15% risk for fetal demise. Commonly survives to 32 weeks or more gestation. And finally, the complication of a monochorionic twin is congenital anomalies. Monochorionic twins have higher rate of congenital anomalies than dichorionic twins and singletons. Obviously, because they are splitting, isn't it? The single zygote is splitting into two. So when it does so, there can be a higher rate of congenital anomalies, including conjoined twins, which is a big anomaly if the splitting occurs after 13 days, which I told you right in the beginning of the class. The anomalies have high rate of concordance though. Even if there are anomalies, the anomalies are equally distributed because the genetic endowment may be the same for both if the anomaly is related to genetics. But can be discordant. Now, this discordance is because of the splitting problem, right? So even if there's equal splitting, then there can be concordance. If there's unequal splitting, there can be genetic as well as splitting problems. There can be discordant. So having dealt with all the problems of monochorionic twins, now I come to the miscellaneous issues in this. Whether to give steroid prophylaxis or not. Yes, it should be given, but beware of pulmonary edema. Magnesium sulfate prophylaxis, if we are trying to deliver them before 32 weeks. Yes, they can be given for neuroprotection. Tocolytics, yes, may be given to allow steroid prophylaxis only, not for a long-term Cerclage. For the first time, I'm saying no. No need of history-based and prophylactic, so-called prophylactic cerclage or empirical cerclage. Yes, if the cervical length has reduced because of mechanical pressure, maybe you can consider cerclage, but that is also not going to hold the pregnancy for long, maybe to overcome a short period or to give a window for steroid prophylaxis or magnesium sulfate prophylaxis. You can do that. Otherwise, a routine cerclage is not indicated. Progesterone supplement, yes, can be given. Suppose the patient, because of over distension of uterus, gets into contractions, or because of any of these membrane separations, or due to your laser procedure, amnioreduction, if she gets into preterm labor situation, you can give progesterone supplements. Pessary, in doubt, better to use, may be given, though the evidence is not very much in favor of pessary. Bed rest is one thing very clear, not beneficial, but it can be harmful as well. I think I've shown this slide day before yesterday also. What is the route of delivery in general? In general, whatever may be the problem, TTTS, TAPS, or SFGR, single fetal demise, or even anomalies. What is the route of delivery? The choice of route no different from other twins, where there is no problem at all. Amnionicity and fetal presentation at the onset of labor affect the choice of delivery. In other words, the routine indications for twin delivery. If the first of the twin, based on the first twin, if the first of the twin is transversely or breech, it's for cesarean section. Based on the second twin, if the second twin is less than or more than 20% of the first twin, if it is absolutely less than 1,500 grams or less than 34 weeks, again, you may consider cesarean delivery. Sometimes if the second baby is having breech and the first baby is having vertex, there is a chance of sometimes interlocking of the twins. Then also you may consider a cesarean delivery. If it is monoamniotic twins, monochorionic, monoamniotic twins, cesarean is the only option. If there are other obstetric indications like placenta previa, it's for cesarean section. So in other words, you will take decision based on individual case. Thank you very much for your patient listening, and I conclude the management of monochorionic twins, and I'll come up with a new topic day after tomorrow. No class tomorrow.